Okay, guys, again, for anyone who wasn't on a couple minutes ago, I'm Dr. Jack Ogilvy. I'm with Central Ohio Urology Group and IR Centers. I'm very happy to have you all tonight for our presentation, and we're going to be talking about management of benign prostate hyperplasia, and specifically a procedure that I do with the urology group called prostate artery embolization in detail. Tonight's presentation, I'm going to run through slides and kind of go over everything that I wanted to talk about. At the end, we will do some questions and answers, which if you think of questions during the procedure, you can enter them. There should be like a chat box or a Q&A box that you can enter the questions in, and I will review those at the end and answer the ones that I'm able to. I do ask that people avoid putting in personal or specific medical information in those. Just try to ask general questions about the procedure and that kind of thing. But again, I'm Dr. Ogilvy. I'm with the urology group, and we can go ahead and get started with the presentation here. So just to talk a little bit about the background of my specialty first before we kind of get into the actual procedures. So again, I'm an interventional radiologist. I'm a little bit different than a urologist, although I do work for the urology group here in Columbus. My specialty is really one that deals in minimally invasive procedures that use imaging guidance. So like X-ray, ultrasound, CT, that kind of thing. That's what I'm trained in. Basically, everything that I do is done through a needle poke in the skin, and then I use the ultrasound or I use the X-ray to actually see what I'm doing within the body. So it's all very minimally invasive, and we're able to actually accomplish quite a bit through those approaches, and that allows us to do procedures more safely, more efficiently, that kind of stuff. Again, I do work specifically for the urology group. So even though I'm a different specialty, I work very collaboratively with the urologists of our group. We all use the same medical systems. They're sending me referrals, and I'm able to see all the information that they're sending me. We discuss patient cases very closely all the time. And my setup is actually not one that's based in a hospital. I actually work out of one of the urology group office buildings in Worthington, Ohio. And from my standpoint, I think that's really nice for these types of procedures because a lot of them you really don't need to do in a hospital. You can kind of avoid a lot of overhang and excess excitement that comes with a hospital setting. Really, it's easy in and out from an office like ours. Recovery is very quick. And I think we're just able to focus a little bit more on the patient and kind of really personalizing care, which is a nice quality, obviously. Interventional radiologists in general really touch all the different areas of the body. We have a number of different procedures and different disease processes that we're able to work on. Again, my focus working for the urology group is primarily urology-related procedures, but I do some other procedures as well. We take referrals for hemorrhoid embolizations, for urinary artery embolizations, which is kind of a similar process that can happen in females and those kind of things. So there's a lot that we're able to accomplish. Really, the prostate embolization is the most common procedure that I do, though, with the urology group. That's the biggest reason I'm there. So first, to just kind of introduce, some of the ideas behind sort of how we work up benign prostate hyperplasia and how we address the symptoms that people deal with. So, benign prostate hyperplasia is a very common issue, unfortunately, in men as we get older. It's something that a lot of people deal with. But because it's common, that means that there's been a lot of research on the different treatment methods, and a lot of thought has been put into kind of really developing an algorithm for how to approach working up patients and then treating them. And that's good because that means that, again, a lot of what we're doing and when we're making recommendations to have a certain study done or a certain procedure, it's evidence-based. We know that's kind of the best approach for a given patient. And obviously everyone's a bit different, and so we do want to personalize everyone's specific workup plan and everyone's treatment plan. But at the same time, there's a lot of overarching principles that are kind of guiding what we're doing. And so that's always worth discussing, especially with benign prostate hyperplasia, or BPH. I'll refer to it in short, kind of moving forward as BPH has a lot of different potential procedures and different medications and different things that can be used. And so it's very helpful to kind of know, which procedures or which medications work for certain patients better than others, and really kind of try to stratify things that way. And so on the left side of this image, at the top here, we include some of the common workup that is done for patients as they're initially getting diagnosed with BPH, and we're kind of addressing their issues. Cystoscopy is probably the most common thing. That's kind of the mainstay of BPH workup, and that's where a urologist is actually looking up through the urethra with a camera, and they can see the inside of the bladder, they can see the inside of the prostate, and directly see evidence that the prostate is obstructing the flow of urine. TRUS, TRUS, or transrectal ultrasound is another thing that we commonly do nowadays to actually measure the size of the prostate and also the shape of the prostate. And these are both important factors that play into what procedure we offer different patients. And then the Uroflow and the Urocuff are some newer technologies that we have, but they're also very helpful in working up these patients, just because these are studies that actually measure the flow rate of urine. They measure the pressures that the bladder is able to generate, things like that. And so we can really pinpoint the prostate as the issue and make sure that there's not an underlying bladder issue or something else that won't necessarily respond to prostate treatment before we start going down these treatment algorithms. So at the bottom of that picture, you'll see kind of a general flow chart or outline of kind of how we might stratify patients into different categories and sort of determine what might be a good option for a certain patient versus another. And you'll see common things that what we're thinking about when we're working on patients. Are they fit to undergo surgery or general anesthesia? Or do they have other medical issues that might make general anesthesia an unacceptable risk? What is the size of their prostate? Are they on blood thinning medications? All these different things play a role. And just to kind of point out one thing quickly, you'll notice, you'll see a lot of different procedures here listed that you may have heard of as well. But one thing that you might notice is that prostate embolization really shows up pretty much in every single one of these categories. And that really speaks to how versatile of a treatment it is, even within this algorithm. And, even while there's a lot of different patients that have different types of prostate issues, often prostate embolization is something that is worth considering. Again, why is this important? Like I said, a lot of people deal with these issues. Over 15 million men in the United States alone end up having issues with prostate enlargement and the related urinary symptoms at some point, in their lives. And the unfortunate reality of these problems as well is that they can be a bit taboo to kind of discuss and deal with at times. Sometimes a lot of the surgeries that are offered to patients are not great options for a number of different reasons. There might be potential complications, or just the idea of the surgery is not something that someone may want to consider. And so the reality is a lot of people avoid undergoing treatment for these kind of issues for one reason or the other, and they end up kind of making themselves more miserable than they need to be. And I think it's important to kind of discuss these and sort of get the word out that there are a lot of things that we can offer now that can help people quite a bit. So just in general, these are some quick videos that kind of show some of the other treatment options that are out there. So of course, the urologists have a number of different surgeries that they do for the prostate in addition to what I do. Again, I'm specifically doing the prostate embolization, but in the upper left here, we have something called Urolift, which is called a minimally invasive surgical therapy. So it is still a surgery, but it's considered minimally invasive because they're not working through, a big skin incision or something like that. For this procedure, they actually go up through the urethra, and they have a tool that's able to put these implants or clips basically in the prostate tissue and kind of pull the tissue out of the way to help open up the flow in the urethra there, and that can help improve urinary symptoms. So that is something that is still very, very commonly done today. In the upper right here, we have a video demonstrating something called Rezūm, which again is done through this transurethral approach, meaning they're going up through the urethra with a tool. This tool was actually able to insert a needle into the prostate tissue itself, which then uses steam to actually kill off tissue in the prostate and help to shrink it back, again, kind of opening up the channel in there and help relieving the obstruction that the prostate is causing. The bottom couple of images here demonstrates a newer what's called resective surgery that the urologists do, where they actually go in and cut tissue out of the prostate. This is something called aquablation. And this is one where they actually use a device that uses a high-power water jet to basically remove tissue from the inside of the prostate, actually cut tissue away with the water jet. That high-pressure water jet is guided by an ultrasound external to the prostate, and that ultrasound is able to very precisely guide the water jet and make sure that it's cutting away prostate tissue and not getting into other tissue that it is not targeting. And so this one is really nice as far as resective surgeries. Again, it's obviously a bit more invasive than the prostate embolization, but it is good at dealing with larger prostates. It does get good results, and it's something that's becoming more and more commonly done. This is really one of the newer modalities. TURP is one other one, obviously, that's worth mentioning that people have probably heard of, or TURP. And that's that, for lack of a better word, that roto-rooter procedure, which is the kind of the considered the gold standard for prostate treatment. And that's where the urologists are actually going in, and you're using a tool to directly just cut away tissue from the prostate. The aquablation is a similar concept, but because it's using a water jet and outside ultrasound guidance, it can be a little bit more precise as to how it's removing the tissue and really avoid hitting some of the structures that are important for sexual function and things like that. So it comes along with less complications, which is nice. Let's see, get to the next slide here. So just to kind of run through the general sort of management algorithm with benign prostate hyperplasia. Medical management inevitably is the first thing that most people are going to start with because it's the least invasive. It doesn't carry the same risks as undergoing a procedure or anything like that. And for a lot of patients, medications are able to work well for quite a while. For obvious reasons, though, medications have some downsides. Depending on what medication someone is started on, insurance and other things like that, it could be expensive to be on a medication long term. Compliance obviously can be an issue. Being on a medication requires taking a medication, taking another pill every day, that kind of thing. And the reality is a lot of patients do have unwanted side effects from the medications that are used to treat the prostate, just the way that they work. Inevitably kind of has some overlap with sexual function and other things like that. And depending on the patient and depending on how bad their symptoms are, they may find that the side effects are worse than the actual symptoms that they're dealing with from the prostate itself. And so it may not make sense to be on a medication, but medications often are the starting point. Inevitably, even someone that does do well with medications, though, over time, often the medications just work less and less effectively because the prostate tends to grow over time in most patients. That's what we see. And so once medications have failed, or either someone has unacceptable side effects or the medications just aren't effective, that's often when we start to talk about actually doing a procedure for the prostate. And for the purpose of this talk, I'm going to kind of talk about two main categories, which is the prostate embolization or the procedure, the PAE, that I do as an interventional radiologist, and then everything else that the urologists do as far as their surgeries. So urologic surgeries are still done very commonly. Again, the aquablation, the Urolift, the Rezūm, all these things are still done commonly, and they do work very well. For the most part, these surgeries are done through a transurethral approach, like those videos I just showed, where they're actually working up through the penis or through the urethra and working on the inside of the prostate. So that in itself, even though it's considered minimally invasive, it's still more invasive than really what I'm doing, where I'm not working up through the urethra at all to treat the prostate. And I'll talk a bit more about that in a second. Depending on which surgery we're talking about, how long the effectiveness of these different surgeries varies quite a bit. And TURP and aquablation really are the best surgeries as far as duration goes, meaning they can provide the longest symptomatic improvement for someone. I do expect a well-done TURP or a well-done aquablation to last longer than a prostate embolization, but that's at the cost of being a more invasive procedure with more potential complications. On the other hand, some of the minimally invasive surgeries that the urologists do, like Urolift and Rezūm, actually have comparable or potentially, depending on what study you look at, even shorter duration of improvement than a prostate embolization. So again, it's kind of a trade-off for how invasive the procedure is versus how effective it is. But we do find that a lot of prostate artery embolization patients actually have longer lasting results than some of those minimally invasive surgeries that the urologists do. For the most part, the urology surgeries are done with general anesthesia as well. Some of them can be done with sedation, like the Urolift, but a lot of those do require general anesthesia, which in itself is just an extra risk. It makes the recovery a bit more involved, that kind of thing. Whereas the prostate embolization, at least the way that I do it, is done with sedation, where we don't do general anesthesia, actually. And so it's an easier recovery that way. We have some other advantages with the prostate embolization as well. It really has the lowest rate of sexual dysfunction of any of these actual procedures that we do to treat the prostate. And so that's a big factor for a lot of patients. Again, I'm not working up through the penis at all to do this procedure. I'm not directly cutting tissue out of the prostate or anything like that. And I also have no upper limit on the size of prostates that I can treat with a prostate embolization, which again adds to its versatility. A lot of the surgeries that the urologists do when they're working through the urethra from the inside of the prostate can become more difficult as the prostate gets larger. Certainly, you can imagine if you're kind of on the inside working through a greater amount of tissue, it can just be harder to more accurately resect tissue or treat the tissue in a way that's going to provide a predictable result. And so we see with a lot of really big prostates, they're actually really not good candidates for some of these surgeries, whereas prostate embolization can be done with any with really no upper limit in gland size, which is nice. So again, this is just a more detailed slide, kind of outlining some of the advantages and disadvantages of the different treatments that I talked about. Again, just really kind of comparing prostate embolization to the other surgeries that the urologists are doing. Prostate embolization, I expect gets comparable or potentially longer results than a Urolift or Rezūm, but probably not as long as a TURP or aquablation. But again, the prostate embolization really is the least invasive of any of these procedures, and so that still positions it pretty well when patients are considering different options. One thing I will mention with the prostate embolization, I'll talk a little bit more about this in detail, is that we do have what I call kind of a soft lower limit in size of prostates that we treat. For prostates below the 40 to 50 gram size, which a normal prostate's about 20 to 25 grams, below 40 to 50 grams, the prostate embolization can still be effective, but it gets a bit more technically challenging, and that can make it a little bit harder to get as good of a result. And so we say there's kind of a soft lower limit of 40 to 50 grams, meaning, if prostates are smaller than that, we may consider other treatment options. But again, we have no upper limit in prostate size, which is nice. This is an actual video kind of showing what happens. So to actually get into kind of the nitty gritty of what we're doing when we do a prostate embolization. So I work through a needle poke in the skin, basically, to do my procedures like I talked about. And for this procedure, I do ultrasound guidance to guide a small needle into the right femoral artery, typically is where I work from, which I can see well with the ultrasound in the right groin, right where the leg meets the pelvis. There's a skin crease there, and in that area, I can see the femoral artery and guide a small needle into it. From there, I actually use an X-ray, and I watch as I move a really long but really thin wire and tube, and that's the blue thing that you're seeing move along there through the inside of the artery, and I kind of snake through the inside of the arteries like plumbing. I can see those with an X-ray. I can inject X-ray contrast into the arteries every so often as well, and that lets me make a map of where they go around the pelvis, and I use that map to help me steer my little wire and tube into different branches. The wire actually has a shape on the end of it, and as I rotate it, I can use it to kind of pick off different branches and get into those. And so that's basically what I'm doing, is I'm doing this fancy version of plumbing where I steer into different branches, and my goal is to get into the specific arteries that go to the prostate, which is indicated, here, it's listed. And once I get into that artery, my goal is to actually block off the blood flow to the artery, and I do that by injecting small particles that are made of a medical grade plastic. These particles are very inert. They don't really dissolve to any appreciable degree. They are effectively permanent. They also don't migrate because when I inject them, they are too big to fit through the prostate itself. So they get clogged in these small arteries that go into the prostate, but they're held there in place because there's always that forward flow of blood in the artery trying to get to the prostate that holds them there. And so they mechanically block these arteries and reduce the blood flow to the prostate. And by doing that, it actually shrinks the prostate down over time. It basically starves it. On the right here, you'll see an image, I believe is from some animal studies that were done early on when prostate embolization was being developed, demonstrating a normal prostate or an untreated prostate compared to one that had been embolized. And you can see, evidence of basically essentially tissue death as the cells in the prostate die off and the prostate gets smaller. And that's kind of how this actually works. That's the goal of the procedure. This is an actual video showing what I'm seeing as I do the procedure. So in the upper left hand, you can kind of see a little video. This is what our actual field looks that I'm working on. But this little wire is actually going into the artery. This is the right groin of the patient here, and this is what I'm using to work. And then this is my X-ray view that I'm actually looking at. And so I don't know if you guys can see my mouse here, but there's this darker line coming down here. That's my actual little tube or catheter that I'm using to work through the inside of the artery. And you'll see as we work, basically, this is a very sped up one, but we're injecting X-ray contrast into the artery, and this is what that map looks like that I'm using. And I can overlay that map and watch it as I move that little wire and actually pick off different branches. And so as we actually start to work through the arteries, you can see we pick off, and our goal is to get into that specific branch that goes to the prostate, which the wire is now in here. And then once we're there, we inject contrast. We confirm that this is the artery going to the prostate. You can hopefully get a sense on this image. I know it's tough. You might have to take my word for it, but all this dark staining is contrast that's actually going into the prostate that's being injected by this tube. So this is what we're actually seeing. And then we inject those particles and actually essentially clog these arteries up and purposely block the flow to the prostate that way. So in discussing who is a candidate in general for prostate embolization, like I mentioned before, it is a very versatile procedure. I mean, there's a lot of different patients that this procedure can be effective in. Really, the most kind of basic indication for this is someone that has prostate enlargement. Again, with that soft minimum gland size of 40 to 50 grams, meaning we want their prostate to be above 40 to 50 grams in size. Usually we want them to have tried medical management and failed it, meaning if they either have side effects or, for some reason the medication is not an option for that patient, it doesn't work, and we're considering an actual procedure. So that's the general indications, and obviously that's a pretty broad, a subset of patients. There's going to be a lot of people that meet that category, and so really anytime someone is considering an actual procedure for the prostate, I think prostate embolization is worth considering as an option because it is the least invasive approach. There are other factors certainly that play into deciding, who we offer this to. I'll mention that we do treat glands smaller than 40 to 50 grams in certain scenarios. Certainly, if there are other factors that make them a good candidate for a prostate embolization, but maybe not a good candidate for other surgeries, we would still consider treating. And often we can still get good results. It just, like I said, makes it a bit more technically difficult when the prostate is smaller than that cutoff. That might limit how effective of a result we can get, but it remains a very safe procedure even in those patients. For patients that have blood in the urine, this is an excellent procedure because the way that I'm treating, again, is directly reducing the blood flow to the prostate. And bleeding from the prostate is something that can happen, especially in really big prostates or people that have prostate hyperplasia. And so this is commonly offered as a procedure when someone has bleeding from the prostate that is persistent. One of the more common things that we're doing that we're more excited about, especially in our urology group, is this aquablation surgery that I mentioned before. And in some patients, we'll actually do a combination therapy where I do a prostate embolization before a patient goes on to have an aquablation done. And the reason for that is that the aquablation, while it works very well, the one kind of downside of the aquablation is that they can deal with bleeding from the prostate while they're actually doing that procedure because that high power water jet that they use to cut away the tissue is not heated, so it does not cauterize the prostate tissue. And they're able to treat very big prostates with the aquablation, but also big prostates tend to be the ones that bleed a lot. And so in a lot of those patients, they will send them to me for a prostate embolization first to reduce the blood flow to make it easier and safer for them to then do the aquablation. That's actually something that we do now, which is very nice. There's a number of other different factors. Again, some of the big ones, someone that's not a candidate for general anesthesia because of other medical issues that they have, can still often undergo a prostate embolization because we're able to do the procedure just with sedation, which I'll talk about a bit more in a second here, and things like that. Patient preference is something that plays a role here too. If a patient is very adamant that they do not want a transurethral procedure done, prostate embolization would be worth considering because, again, we're able to treat the prostate without having to work up through the penis or through the urethra, and that kind of thing. And so really, like I said, it is a versatile treatment. To talk about the results of prostate embolization, it is an effective procedure. We see that for patients that are a good candidate for this procedure, 85 to 90% of the time we get good results, meaning we see patients have significant improvement in their urinary symptoms that they're happy with. That is purposefully a little bit vague because everyone's a bit different. Obviously, patients' baseline symptoms differ from person to person. And so really our goal is, we want to get someone a result that they're happy with, that they can avoid needing another type of procedure done in the immediate, the near future and that kind of thing. And that's really what we're looking at for success. And our success rates really are comparable. Our initial success rates are comparable to the other surgeries that are out there, including TURP, aquablation, Urolift, those kind of things. Again, the duration of that symptomatic relief may vary from treatment to treatment, but initial results that we get are similar to those other procedures. One of the big downsides of prostate embolization is it does take some time to work. Because I'm not cutting tissue out of the prostate, when I go in and block these arteries off, we then have to wait for the prostate to actually shrink down, which does take time. It actually occurs over weeks to months. And it usually takes about 3 weeks on average from when I start to do this procedure, or when I do this procedure, to when a patient starts to really see improvement. And it could actually take several months before someone sees all of the improvement that they may get from this procedure, even out as far as 5 or 6 months from the procedure. So it can definitely be a more gradual process to get the results. We see from a lot of research that's been done on this that on average, when we block the arteries off that we do for this, the prostate shrinks by 30 to 40% in size. And so in a lot of patients, it's not going to get them all the way back down to a normal prostate size, but 30 to 40% is still a pretty big difference, and it's going to make a big symptomatic difference for a lot of people. And the truth is that it's a little bit more complicated than size as well. There are some people that theorize that embolization of the prostate actually softens the tissue to some degree. It kills off smooth muscle cells in the prostate and these kind of things that can make it easier to urinate as well and things like that. And so it's a little bit more complex than just the size, but to have sort of an actual number in your mind, 30 to 40% is what we typically see. With our procedure, we do have longer term data now, looking at how patients do over time. And we see that on average, patients that have this done and get good initial results go 5 to 7 years before they have recurrence of similar symptoms. So recurrence is something that I do expect will happen with this procedure if you give it enough time. The reality is that when I block these arteries off, it doesn't completely remove all the blood flow from the prostate, so it's not totally dying off. It's not completely going away. It is shrinking down, but at some point it will stop shrinking and it can start to regrow. The body will actually try to grow new arteries and kind of restore the flow that we blocked off. And so symptoms can come back, and we see 5 to 7 years as the average duration with the prostate embolization. Again, I expect that that's going to be shorter when you compare it to some of those more invasive resective procedures like a well-done TURP or an aquablation or something like that. One thing worth noting, though, is that prostate embolization can be repeated and you can expect similar results, assuming that someone did well the first time and got years of relief, but then symptoms slowly came back to suggest that the prostate regrow. We can go in again, block off these new arteries that have grown in over time and see a similar improvement. So, if someone is really wanting to avoid having a resective procedure like a TURP done, you potentially could do, a prostate embolization and then repeat it years down the road if symptoms come back. We do commonly follow what are called an IPSS or AUA score in patients. Again, I mentioned that symptoms vary quite a bit from person to person, but we do try to quantify it in some way. And this is the most commonly used scoring system. We check this on everyone before they have a prostate embolization done. And then we check it at intervals after the procedure as well to kind of assess how their symptoms are doing. Basically, it's a score that ranges from 0 to 35 and tries to quantify how bad someone's symptoms are. So 0 means no urinary symptoms, and 35 means, that across the board they have, in each of these categories like frequency, urgency, they have the worst, the worst rating. We have, I think to try to put an actual, kind of number on sort of our results and what we see with this from our data within our practice itself. We see on average at the time of the first follow-up, which we usually do at 4 weeks after the prostate embolization, we see an average decrease in that IPSS score of 11 to 12 points across patients. And that really is, if you look at kind of how the categories are broken up, again, 1 to 7 is mild, 8 to 19 is moderate, 20 to 35 is severe. So 11 to 12 points could get someone from, a 24 severe down to like a 12, moderate, and that's just at 4 weeks. Again, I do expect that it may take months beyond that even to see the full benefit of the procedure, but that's kind of the improvement that we're actually seeing amongst our patients. To go into some actual details about the procedure itself, it is all same day, it's outpatient. Typically, patients are in our office for a total of around 4 hours to get this done, and the procedure itself usually lasts around an hour. It can be a bit shorter than that. It could be a bit longer if someone had more difficult anatomy, but we're usually close to an hour, if not less. So the rest of that time is just spent getting you ready before the procedure, and then there's 2 hours of recovery afterwards. We do these with sedation. So we do twilight sedation like a colonoscopy. Again, that's what we do in the office. Because this procedure is minimally invasive, it's really not very painful. And I do give some local numbing medication that stings and burns for 10 or 15 seconds right at the beginning. But beyond that, what I'm doing, I really expect is not painful. For the most part, patients wouldn't even know that I was in there actually doing the procedure. So we do give that sedation though, just to keep people comfortable because they're laying flat on their back as I'm working and we want people to be still. But because we do sedation, that means that the recovery is faster. You're not going to go through the same kind of post-procedure grogginess and all that kind of stuff that you might see with the general anesthesia type procedures. Certainly this is a lot easier on the body. Let's see. Again, I mentioned there was a 2-hour recovery period before patients go home. You are in bed rest during that time because that is mainly to help that artery puncture site heal up well after we close that little hole that we were working through. So 2 hours of bed rest, and then you're able to get up and start walking around, and you actually go home at that point. So really not too bad as far as recovery goes. Once patients get home, certainly we go through detailed instructions and talk in detail about what to expect. But the main things to know about the recovery from this procedure are that we do have people avoid heavy lifting for 5 days after the procedure, so nothing over 15 to 20 pounds, just to really help that artery puncture site heal up well so people aren't straining the muscle around that area. But then after that, really, there's no weight limit restriction as far as activity goes. People can shower the day after the procedure. They can drive after the day after the procedure. And really the biggest thing that I do stress about this procedure is that I do actually expect temporary worsening of urinary symptoms initially before things start to improve. The reason for that is when I block the arteries off that go to the prostate, the body's not very happy about that. The prostate wants blood. When the blood gets cut off like this, there's inflammation and swelling that happens. And we do see on average about a week of actual worsening of urinary symptoms from this irritation and inflammation that's happening in the prostate. And so it is a normal thing we expect. It does resolve with time. We still send everyone home with several short-term medications to help them, get people through these symptoms. And I'd say most patients would describe dealing with these symptoms as annoying, but not terrible. And again, it is just something that's kind of inherent to treating this way. It can be normal to have some burning with urination. Some people notice a low-grade fever, these kind of things as well. And so we have some medications that we give people that are targeted for that. But again, most people are back to their baseline symptoms, maybe a little bit more than 1 week after the procedure. And then I expect it's about 3 weeks until someone really starts to see improvement as the prostate then begins to shrink. So this is just kind of a general graph. So we're showing what we expect the recovery to look like. So again, if you start at baseline for that first week or so, we do expect that things get worse from the inflammation that happens after blocking the arteries off. But then they start to improve, you get back to baseline, and then they just continue to improve out to several months after the procedure. The risks of the procedure are very low. Again, this is one of the big advantages of the prostate embolization is that it's a very safe procedure. Because it's minimally invasive, because we're able to do it with sedation, it doesn't carry the same types of risks as an open surgery where there's a big incision that has to heal and that kind of thing. Retention is something I do always mention to patients. In theory, like I just mentioned, we're causing inflammation in the prostate initially before it starts to shrink. That swelling could cause someone to go into retention, meaning that they are completely unable to urinate and they have to actually have a Foley catheter placed, potentially for a week or so to get through that inflammation. That risk is very low with this procedure in general. And for the most part, I'm not placing a Foley catheter or anything like that when I do this procedure because I know that risk is low. There are certain patients where I may recommend placement of a Foley catheter if they're at higher risk of retention, but in general, this procedure does not require placement of a catheter, which is another big advantage of it compared to some of the other surgeries that the urologists do. Bleeding is very rare with this procedure because I'm doing the procedure through a very small puncture in the artery that we're making in a controlled manner. Infection is very uncommon. We do everything with sterile technique, and we do give it antibiotics during and after the procedure. And then finally, the one other risk we always have to talk about with people is that I'm working inside of the arteries. It's possible, and I'm purposefully blocking arteries off. It's possible I could block off an incorrect artery and cause an issue somewhere else in the pelvis. As you saw with that video before, I'm very accurately mapping these arteries out. These arteries do have a very characteristic appearance, and so I can distinguish an artery going to the prostate from an artery that goes to the bladder or to the rectum or to some other area in the pelvis. And so it's very, very unlikely that I would block off significant flow to some area that's not the prostate and cause an issue somewhere else in the pelvis. Which again is a big advantage of this. And one thing I mentioned related to that is the risk of sexual dysfunction. As far as prostate procedures go, sexual dysfunction risk is really the lowest with prostate embolization compared to any of the other surgeries that's out there. The main area that the risk of sexual dysfunction exists with prostate embolization is that I could go in and block off an incorrect artery in the pelvis that could give someone erectile dysfunction or something like that. But again, like I just mentioned, I can be very accurate when I'm mapping these arteries, make sure I'm not treating an artery that goes down to the penis or something like that. And so it's very, very, very unlikely that I would cause any worsening of sexual function with this procedure. which is one of its big strengths. Again, this is just a kind of a review of some of the things that we've talked about. A lot of the factors that make someone a good candidate for prostate embolization. Again, I just stress that it is a very versatile procedure, and it's something that a lot of patients could benefit from. And so it's definitely worth getting the word out there about this, that it is an option. As far as next steps, if this is something that it sounds like you might be interested in, as far as a prostate treatment goes, we do have educational materials that our urologists are all supplied with. They're able to hand out a pamphlet that kind of reviews some of this information. And so I encourage you guys, if this is something that you're really interested in having done, speak with your urologist about it, see if they think that you might be a good candidate. This procedure does require a urology workup. And so typically, self-referrals are generally not something that we get unless it's someone that has had a urology workup somewhere else and is now, seeking us out for a prostate artery embolization specifically. We do want patients to go through the typical workup and make sure they get cystoscopy, get a prostate size and those kind of things before they come to us. But definitely it is worth discussing if it's something that you're interested in. Certainly urologists can initiate that workup and make sure that we go down the right pathway if you think that you might be someone that would benefit. This is some of just my contact information. Again, that's my name. And we do have our own phone number in the IR area with Central Ohio Urology Group that can be called. Certainly feel free to reach out to us. If you do have questions about the procedure specifically for us, I'm happy to chat with people as well. Again, that phone number goes to my front desk scheduler, but she's always able to get in touch with me too. But I'm more than happy to answer questions and those kind of things as well. If you think of something and want to reach out to us. So at this point, I want to take a look and see if we have some questions to answer, and I will kind of run through those. So let's see. Okay, so I'll start with if Urolift has already been done years ago, is this an option? So yes, it is. Actually, that's one of the common scenarios that we see as patients that have had other procedures done and have had regrowth of the prostate or return of symptoms. They often will get referred for a prostate embolization as a different approach, and we do have a lot of data that supports that prostate embolization really works regardless of prior surgeries, including Urolift. So even the fact that those implants are in there in the prostate, that will not interfere with the ability of us to go block the arteries and still shrink the tissue back around those clips. So that can safely be done. If someone's had a prior TURP, if someone's had a prior aquablation or HoLEP or one of the, Rezūm, any of these surgeries, we can still do a prostate embolization on those patients. I have, is this procedure covered by Medicare and just insurance in general? I would say in general, it is covered by insurance. Medicare specifically is very good about covering this. We actually really don't get denials from Medicare. Other insurers in general will cover this. Occasionally we do get denials and we have to appeal them or something like that, but it's uncommon actually. Surprising, or maybe not surprising, but because the data is good, but we do occasionally get denials for reasons that are kind of difficult to predict and we have to appeal or something like that. I will say that almost all insurers are going to approve a prostate embolization for a prostate that's above 100 grams in size or a prostate that has bleeding as one of the indications for doing the procedure. But even for prostates that are smaller than that without bleeding, it is generally covered. This is something that whenever we do a consult with a patient and decide to move forward with the procedure, we do run an insurance authorization ahead of time to make sure that it will be covered. So it is something that we figure out before the procedure, obviously, because we don't want to get people stuck with a big unexpected bill or something like that. I have someone asked, will I be able to stop taking medications for the prostate after having this done? So that is a reasonable goal. Certainly, as we improve symptoms by shrinking the prostate, I would expect that a lot of patients that are on medication are able to cut back on those or even come completely off. We do get some patients that have they're on medication and their symptoms are reasonably well controlled, but again, they might have a suboptimal side effect or something that they're dealing with, and so their main goal is to get off of medication. And those patients, we would consider doing a procedure like prostate embolization to try to get them off of medication. So that is a reasonable goal. And Sorry, I see the correction from fleconide to finasteride. I knew you were probably trying to refer to finasteride there, but yes, we do see a lot of patients. Everyone's a bit different. Certainly, I think there are some patients that get improvement and they're able, maybe they're on double dose Flomax or something like that, and they see a lot of improvement, and they are able to cut back to single dose Flomax or something like that, but they may still need to be on something to kind of keep things flowing well. So success sometimes can be a spectrum, but often patients are able to come back. It does take time to see the improvement from the prostate embolization, though. So coming off of medications often is something that doesn't happen until several months after the procedure has actually been done to really get let the full effects of the prostate embolization kick in before stopping the medication. How long after prostate embolization is it safe to have sexual activity? That's a good question. I typically tell patients to give it 2 weeks. Really, the biggest limitation I would say is that weightlifting restriction I kind of talked about before. I do kind of qualify sexual activity as potentially being strenuous. And so from that standpoint, from making sure the artery heals well, at least 5 days. Beyond that, there can still be some lingering inflammation of the prostate. And some of that inflammation can cause adjacent inflammation sometimes of the other structures like the seminal vesicles that are responsible for producing semen and things like that. And so it could be normal actually for a couple of weeks after this procedure to see like blood in the semen or something. And for that reason, I usually tell people to give it a couple of weeks, like I said, 2 weeks, to really let things calm down and kind of let things start healing up before you get back to that activity. But beyond that, it really should not be an issue. Some patients may notice some discoloration of semen that may persist for a month, or so after the procedure from this inflammation, but that typically clears up over time and otherwise isn't really an inherent issue or something like that. I do have someone asking a little bit kind of about my background and my experience with prostate embolization. So I've been working with the urology group now for over a year. I actually started in August of last year. And during that time, we've done close to 500 prostate embolizations at our center, which is, from my standpoint, I think easily probably more than anyone else in Ohio. Certainly our group of interventional radiologists, I'm part of a bigger network with IR centers that has similar setups to me across the country. I would say in general, our doctors are probably doing more of these procedures than just about any other interventional radiologist that you run across, really, because this is our main focus with these urology groups. Let's see. I have someone asking, this is a more specific question, which is asking about having previously seen a urologist and talking about this as a prior option, but it sounds like they didn't move forward with it at the time. So if it's been several years since you really kind of discussed options or had a workup, I would recommend talking to the urologist again. It may, depending on where your symptoms are in your situation, it may be indicated to have, new workup. That's not always the case. If things seem like they're pretty similar, they may feel that that's enough information to go on. But I would probably talk with the urologist again before deciding kind of exactly how you want to move forward. A question about just prostate size, how that's determined. Again, there's different ways we can image the prostate to get a measurement. Transrectal ultrasound is the most commonly done amongst urologists because it doesn't require a radiation like a CT scan or something like that. It's a lot less expensive than an MRI, and it can be easily done with cystoscopy at the same time. So the transrectal ultrasound is the most common thing, but depending on the circumstance, if someone has a recent CT, I can look at those and measure the size of the prostate off of that, assuming that it covers the pelvis. Some patients do get prostate MRIs because they have elevated PSA, for monitoring a prostate cancer and that kind of thing. And that would come with a prostate size. So there's a number of different ways, and it kind of depends on someone's specific circumstance. But in general, we're getting the size from either transrectal ultrasound, a CT, or an MRI. I'd say those are the big three. We have a question, just how long has this procedure been around for? It's actually been around for over 15 years. It is not a new or experimental procedure by any degree at this point. It's really well established. It has become a lot more popular over the last 5 years, specifically because data has accumulated over time showing that this is an effective procedure. We now have longer term data showing its efficacy. And as that has accumulated, the urologists have gotten a lot more on board. with sending patients for this. So that's why it's become more common in the last 5 years, but it is not a new procedure. It's been around for 15 plus years at this point. Let's see. Good question about what happens to the prostate tissue after this procedure. Basically, where does that extra tissue go as the prostate shrinks? So, in general, what's happening when we block these arteries off is we're causing ischemia or low oxygen levels, basically, to the cells in the prostate gland. That results in some of these cells dying off, and as they die off, for the most part, they are cleared out by our immune system, and that's actually what results in the shrinkage of the prostate. It's rare that enough tissue death would happen in one area that a piece of the prostate would actually break off from the inside. In theory, that can happen, but it's pretty uncommon that we actually see that. Even if that did happen, really what that potentially would cause is it could cause temporary obstruction of the urethra as that tissue passes, or something that someone might need a urinary catheter for temporarily. But that tissue would break up on its own over time. And so I wouldn't expect that to cause a long-term issue, even if it did happen. Occasionally, I do hear patients tell me about passing small bits of debris in the urine after this procedure, for a couple of weeks. And I'm never really sure if that's actual, tissue from the prostate, or if it's just debris that was in the bladder that previously wasn't able to get out. And as that prostate obstruction is improving, that debris starts to make its way out. But it's uncommon that those little bits that are noted are causing any issues. Again, there's something that just passes in a painless way. But for the most part, the tissue is basically being absorbed. It's, cells are dying off and the immune system is clearing them out. Let's see. Yes, I do believe this presentation is being recorded, and so this is something that should be available after tonight's presentation. I'm not sure if it's posted on YouTube or a similar outlet, but there should be a recording of this that is able to be accessed. I think that attendees will get an email afterwards showing where this is able to be reached if someone wants to review it. So there's a question about who does this at COOG, or who does this with the urology group. So I'm the primary physician there. I do have some other physicians that occasionally do these procedures as well here. They are part of our IR Centers network. So they are still in a similar role to me, doing primarily prostate embolizations. And for the most part, they're even more experienced than I am. And so regardless, of who does it, it's going to be someone that's very capable, and you'll be in good hands. But for the most part, I'm the main physician that does these at the urology group. I think that's all of the big questions that I saw on here. I apologize if I missed anything, but I think I got through most of them. So, and it is 7:50 now. So I'm going to go ahead and wrap things up. Again, I do think that there will be a post seminar email that'll go out to everyone who attended tonight, and I think that will include a link to show where this recording can be accessed for someone that wants to go watch it down the line or something like that. But otherwise, again, it's this is something that we're really excited to be able to offer at the urology group. Again, we've been set up here for over a year now, and have seen a lot of great successes, and really we hope that we can continue to spread the word about the procedure, continue to help more and more patients out through our setup here. But I appreciate all you guys being with me tonight. Certainly very fulfilling from my end to be able to kind of talk about this, and like I said, spread the word. So hope everyone has a really nice evening, and I will let you guys go.